Well, thank you very much for this introduction. I'm very happy to be here with all of you to discuss a very good medication, Isatuximab in relapsed myeloma, which we use to achieve very deep responses. And so you are all aware that Isatuximab is a monoclonal antibody against CD38, which is a glycoprotein that is highly expressed in myeloma cells. CD38, of course, functions as a receptor and an enzyme, and it has several functions. Isatuximab also then what it does is a monoclonal antibody that targets a specific epitope on the CD38 protein. And this is distinct from other anti-CD38 antibodies. It also has several mechanisms of actions, such as immune-dependent cytotoxicity with ADCC, CD3, and ADCP. It also has dependent apoptosis of the myeloma cells. It also inhibits the enzymatic activity of CD38, and it contributes to immunomodulation of other immune cells. Isatuximab is approved in relapsed myeloma in combination with pomalidomide and dexamethasone with patients who have received 2 prior therapies, including lenalidomide and a proteasome inhibitor. And it is also approved in combination with carfilzomib and dexamethasone for the treatment of adult patients with at least 1 prior therapy. Isatuximab was studied in preclinical data in combination with other standard myeloma medications, such as the IMiDs and the proteasome inhibitors. And we can see here graphs showing the enhanced anti-tumor activity with pomalidomide, bortezomib, and carfilzomib. Isatuximab also binds to a different CD38 epitope than daratumumab, and it has differential activity. It has 5 times less extracellular ADPR. It also has direct apoptosis in the absence of cross-linking, and it does not result in decreased CD38 receptor expression. Because of this, Isatuximab has complementary anti-myeloma mechanisms and other drugs that enhance all these effects. Isatuximab is also approved by the FDA, and the NCCN guidelines recommend the use of Isatuximab in combination with pomalidomide or carfilzomib and dexamethasone in patients with early relapse that have received 1 to 3 prior lines of therapy. And this is a very strong recommendation, as we have very strong data from randomized large phase 3 studies that we will review. Additionally, Isatuximab is also recommended for relapsed patients in combination with pomalidomide or carfilzomib in patients starting with the 2nd line of treatment for relapsed myeloma. Additionally, there is a very active investigation of Isatuximab in all the myeloma treatment continuum, starting with patients with smoldering myeloma, where the ITACA study is randomizing patients to either lenalidomide dexamethasone alone or lenalidomide dexamethasone with Isatuximab, and this study is accruing. There have also been a number of studies performed in the frontline for newly diagnosed myeloma, some of them in Europe and the US, including the investigational treatment from the European Myeloma Network, 16405 with KRD and Isatuximab, and also investigations of RVD and Isatuximab from the German group, and also sponsored study in ROS. We're going to review more carefully today the IKEMA and ICARIA data, which is the combination of Isatuximab with carfilzomib and pomalidomide in relapsed myeloma. Both of these studies showed that there was markedly improved progression-free survival in relapsed myeloma when you added Isatuximab to the regimen of pomalidomide dex or carfilzomib dex. Additionally, the German study in the newly diagnosed setting also met its primary endpoint of improving minimal residual disease negativity after induction, again in newly diagnosed myeloma. So we're going to start with the ICARIA study. The ICARIA study was a large phase 3 randomized study of a combination of Isatuximab monoclonal antibody with pomalidomide or dexamethasone versus pomalidomide dexamethasone, where 307 patients were randomized 1-to-1 to either of these 2 groups. The primary endpoint of the study was the progression-free survival with key secondary endpoints, the overall response rate and overall survival. As you can see here in the patient characteristics, the patients were overall on the younger side for myeloma, 68 on the ISA-PD and 66 on the PD arm. And what you can see is the patients had about 3 median prior lines of therapy with a range of 2 to 4. You can also see that all the patients have been exposed to previous proteasome inhibitors and immunomodulatory drugs, and actually a lot of them were also refractory to these medications. When we look at the progression-free survival in the study, we can see a markedly prolonged progression-free survival favoring the ISA-PD group compared to PD. And we can see here that the median progression-free survival with ISA-PD was 11 months. We can also look here the overall response rate and the depth of the response with a median follow-up of 35 months. And we can see that the ISA-PD arm had markedly improved overall response rate compared to PD, with the response rate being 63% compared to 32%, and the rate of MRD negativity being 7% on the last data cutoff to 0% with PD. So this means that the responses with ISA-PD continue to improve after additional 2 years of therapy. ISA-PD has a very manageable safety profile, can be given in even in practice, I can tell you, in older patients without a lot of adverse events. And what we can see here is, yes, we can see that there were a little bit more grade 3 adverse events overall in the ISA-PD than the PD group. Most of these were related to infection or some hematologic cytopenias, such as neutropenia, thrombocytopenia, and anemia. Despite this, however, there were no more deaths due to treatment in ISA-PD compared to PD. And also, there were not a lot of adverse events leading to discontinuation, which was similar in both arms. Another important thing about exploratory analysis in this study was the efficacy of the treatment based on subsequent daratumumab therapy. What we can see in this slide is for patients who received daratumumab as a first line of subsequent therapy after Isatuximab, the median progression-free survival was lower in the patients that had received Isatuximab compared to those that had not received it. However, there was no difference in responses when you gave daratumumab in combination with other medications, other anti-myeloma drugs, compared to monotherapy with or without steroids. And this is important because it highlights that you could use Isatuximab first and daratumumab later in the same patient with efficacy. In this sense, here we have data looking at Isatuximab after daratumumab therapy. This is a retrospective study that we conducted at MD Anderson in Houston, Texas. And what we saw is that the best response in patients that had had any type of daratumumab before, we had the response of up to 89% in patients receiving Isatuximab afterwards. But for patients who had received, for example, the regimen ISA-PD, just after they had received daratumumab, the overall response rate was up to 53%. So this is very important because it means that you can actually treat again with a CD38 antibody in patients, especially when you're giving in combination with another agent, and that may be different to what they received first with daratumumab. And it speaks towards the fact that there could be different mechanisms of action that we have discussed in Isatuximab versus daratumumab. We're not going to discuss a very good study that has given very good results. This is the combination of carfilzomib, dexamethasone with Isatuximab. This is the IKEMA study. And in IKEMA, there were 302 patients that were randomized 3-to-1 to either ISA-KD or KD, as you can see here. And the patients received treatment here until disease progression and acceptable toxicities or patient withdrawal. There were some key exclusion criteria where patients must not have received prior therapy with carfilzomib, and they must have also failed to achieve an MR with prior anti-CD38 antibody therapy. If they had failed to achieve an MR, then they were not eligible. Again, the primary endpoint of the study, such as an ICARIA, it was a progression-free survival with key secondary endpoints of response rate, minimal residual disease negativity, and survival. So this is the treatment schedule of this study, where you receive Isatuximab weekly for the first month, and then after that you receive it every 2 weeks. Carfilzomib is given 2 days in a row weekly for 3 weeks with the dexamethasone, which is also given on the week off, basically continuously. The baseline characteristics for the patients on the IKEMA study, you can see them here, and you can see that there were quite a lot of patients that were older in age, quite a lot of patients with high-risk cytogenetics, 23 and 25%. This is quite a lot. And you can see that this was very early relapse with a median number of prior therapies of 2 and a range of 1 to 2 therapies for ISA-KD and 1 to 3 therapies for KD. Most of the patients had also received prior proteasome inhibitors and IMiDs, and a lot of these were also refractory to IMiD and PI. What we can see here is very good results of the first interim progression-free survival analysis with the primary endpoint that demonstrated that there's a 47% reduction of the risk of progression or death with ISA-KD versus KD. You can see here the progression-free survival curve is very good, and the median progression-free survival has not been reached in ISA-KD, whereas it has been reached in KD of 19 months. So these are very important results, and it's giving us data for a very impactful and effective regimen in early relapse in myeloma. When we look at the responses as well here of ISA-KD compared to KD, we see that they are much deeper in ISA-KD. And what it means is, we mean by much deeper is, for example, the rate of very good partial response was 73% compared to 56% in KD. The duration of the response was also longer in the ISA-KD arm, and the depth, the quality of the response also favored ISA-KD. There were also some impact of the M protein interference because Isatuximab is an IgG a monoclonal antibody which can be picked up in the electrophoresis. So when we do adjustment of the complete remission rate by mass spectrometry, we can see that the complete remission rate actually was 45.8% in this study, which is a very, very good complete remission rate in early relapse in myeloma. We can also see that the MRD negativity rate with ISA-KD was 30% in the intention to treat population. Again, very important, we saw about half the patients with complete remission and 30% of all the patients with also MRD negativity, which clearly favored ISA-KD compared to KD. When we have the overall survival data here with a median follow-up of 20 months, so this is very early and it's very immature, so we need to keep following this. Again, with the IKEMA study, even though there were more grade 3 treatment adverse events, the addition of Isatuximab to KD does not increase the mortality, the serious adverse events that lead to discontinuation or death. And so this is very important, as you can see in this arm. The other thing is also that the patients received most of the dose that they were planned to receive. And also the duration of the treatment is longer than in the KD arm. And so this really demonstrates that this is a combination that is feasible, that patients can take for a longer period of time. We can see here again some of the most common treatment adverse events in these patients. Of course, we have the infusion reactions with Isatuximab. There's also hypertension, which is usually attributed to carfilzomib. And then we have also some infections. There was also a rate of heart failure, which was similar in the two groups, and also there were cytopenias. In terms of the infusion reactions, the infusion reactions really occur usually during the first infusion. And this is during the day of the infusion or the day after. All the infusion reactions were in this study were grade 1 or 2, except one patient who had a carfilzomib-induced grade 3 infusion-related reactions. These infusion reactions are really reversible, and there's only one patient that discontinued due to the infusion reaction. And I have to say, in my practice, we usually have an incidence of infusion reaction that is much lower. And so I think that you can really modulate the infusion reaction based on the premedications that you give to the patient. When we look at the updated progression-free survival and depth of response in IKEMA, what we see is that, again, we can continue to see improved median progression-free survival with ISA-KD, with this time at median follow-up of about 30 months, that the progression-free survival was 35.7 months. And as we mentioned before, in KD it was 19 months. So this is one of the best progression-free survivals that we have in myeloma in second-line therapy or in early relapse. So this is a very important finding. And also we have very good rate of MRD negativity with 33% of the patients having MRD negativity with ISA-KD and 26% MRD negative with complete remission, compared to 15% and 12% in PD. What we can see here through progression-free survival after patients receive another line of therapy is that the median progression-free survival was 47 months compared to 35 months with KD alone. So this again argues that you want to give your best treatments up front, and when patients relapse, when they have even their first relapse, if you give them a regimen such as ISA-KD, this can really have an impact on the patients. The safety findings were very similar on follow-up analysis as we had discussed before. So these results really show an unprecedented median progression-free survival, complete remission rate, MRD negativity rate, and CR rate in a regimen that does not have lenalidomide or pomalidomide. And this actually benefit is also maintained throughout subsequent therapies with a very manageable safety profile and really supports the use of ISA-KD in early relapse in myeloma. I have now a couple of cases that are my own cases in the clinic with patients that have actually received treatment with Isatuximab and have done extremely well. So we're going to discuss an older lady who was 81-year-old when she was diagnosed with smoldering myeloma in 2015. And at that time, she had basically up to 20% plasma cells in the biopsy and had quite a lot of serum free light chain in the blood. But this patient was monitored for a few years. However, then there was fear that she would get into kidney failure with a light chain of, a serum free light chain ratio, what was consistently above 400 and increasing. And so this patient received treatment for her multiple myeloma with carfilzomib, lenalidomide, dexamethasone, and had a very good partial response. And then had a dose-reduced melphalan 140 milligrams per meter square autologous stem cell transplant with a still very good partial response. And after that, she went on a clinical trial with Isatuximab, which is an anti-CS1 antibody, and lenalidomide. And she did really well with these for about 2 years. And after that, she relapsed. After that, she went on daratumumab. So this is a patient that we're now, in her second line treatment with daratumumab, and was on a trial where you would get daratumumab bortezomib for the first couple of cycles, and then you would switch that to daratumumab and ixazomib. So this patient was on this study for about a year on the bortezomib, and then another year ixazomib and also daratumumab. Ixazomib was stopped a few months before she came off the treatment due to neuropathy, and basically she remained on daratumumab, that 1 monthly, infusion. So this patient was refractory to daratumumab, Tuvilo, and lenalidomide. Those are the medicines she was refractory to. And then, based on the results of the studies, IKEMA, we studied her on Isatuximab, carfilzomib, dexamethasone, and she's now had 8 cycles of treatment, and she has a partial response. So this is an example of one of these patients that we saw that had a good response after treatment with daratumumab. And even when she was refractory to daratumumab, when she received Isatuximab and carfilzomib, she's having a very good response and she's doing very well. So these are the light chains of these patients, and she started treatment around, in October of 2021 with a kappa of 128, which has consistently been coming down to 57. And so this has been a very effective regimen for this patient, and she's doing really well. She's in her mid-80s. She really is not having a lot of major side effects from this. So it's a very good tolerated regimen in myeloma patients. We have another case here. This is the last case of a 66-year-old man that has also diagnosis of multiple myeloma when he presented with a right shoulder pain with lytic lesions in the scapula. Additionally, when we did the workup, we saw that he had additional other lesions in the body and basically had an IgG kappa myeloma, 2.9 grams per deciliter, and a ratio of 47, had some benzoate proteinuria as well, and 60% plasma cells in the bone marrow with a gene expression profiling of low risk, hyperdiploidy, and CKS1B positive monosomy 13 on FISH. So this patient was treated in 2015 with bortezomib, lenalidomide, dexamethasone, and then went to a autologous stem cell transplant with busulfan and melphalan, got a complete remission, went on lenalidomide maintenance, which is a very typical process that we do in the United States. However, this patient started developing worsening thrombocytopenia. And so we stopped the Revlimid, lenalidomide, and he still had this thrombocytopenia after 1 or 2 months, which is unusual if it's due, so it wasn't really due to the lenalidomide. And what we did was we did a bone marrow biopsy, and this showed myelodysplasia. As you know, it is very common in patients with multiple myeloma, especially after they have received alkylating agents such as melphalan or busulfan, to have myelodysplasia or leukemia as secondary cancers. And so this is what this patient had, and we referred this patient to leukemia for evaluation. And this was, in 2019, and then COVID happened, and the patient, kind of didn't come back, was lost to follow-up for a couple of years. And he came back to our clinic in March, and at that time, March of this year, and at that time, he still had myelodysplasia, which was worse than it had been, a couple of years prior. And so the leukemia doctors put him on the cytarabine for a couple of months, and they planned to send him to an allogeneic transplant. At that time of the analysis in March, the patient seemed to be in complete remission. And so after he received the treatment with the cytarabine, 1 cycle, a repeat bone marrow biopsy showed that now he had 80% involvement by myeloma. This is also very common when you have patients with MDS or leukemia and they have myeloma at the same time. When you treat the leukemia MDS, then it's like it's not you let the myeloma flourish, but the myeloma actually get worsened for some reason. So we decided to treat this patient then just very recently with isatuximab, carfilzomib, and dexamethasone, because we are trying to avoid lenalidomide and pomalidomide, which could potentially exacerbate myelodysplasia. So this is a regimen that doesn't contain IMiDs. And so the patient actually just got 1 cycle of this treatment. He tolerated it quite well, even though he has cytopenias because of the myelodysplasia. He was able to receive actually most of this regimen for the first cycle and got a very good partial response. And when we repeated the bone marrow biopsy, the myeloma was gone after just 1 month. And we saw just some blasts from the myelodysplasia, which was expected. So this patient is completing a 2nd cycle now of this regimen. And once this is completed, then the patient will be able to proceed to an allogeneic transplant, which is going to be life-saving. So this is just to speak how well these regimens work for our patients. So in the key conclusions for this presentation, we are going to reiterate that isatuximab is a monoclonal antibody that targets a very specific epitope on CD38 and has a lot of mechanisms of action into how it kills myeloma cells. The efficacy of isatuximab has been proven in preclinical and early phase studies as monotherapy and also in combination with PIs and IMiDs. The phase 3 studies of isatuximab in combination with the standard of care backbones in Icaria and also in leukemia are very representative of clinical practice. And as I presented in the cases, we can see very similar results in standard of care without clinical trial. In the combination of ISA-PD, there was a statistically significant PFS benefit consistent across all the patient groups, including difficult to treat groups, and an improvement in the response rate and better depth of response compared to PD in this study, Icaria. In the IKEMA study, the ISA-KD combination had a very much improved progression-free survival versus KD. And this was consistent in all the subgroups, even including difficult to treat subgroups, specifically high-risk patients as well. And ISA-KD was associated with an improved depth of response, and this depth of response continued many months afterwards. This is actually one of the, again, best progression-free survivals we have in phase 3 studies in myeloma in early relapse. And of course, isatuximab has a very manageable safety profile, a very good benefit risk ratio and very similar rates of fatal treatment adverse events between arms in the study. And there was no increase in treatment discontinuation in these phase 3 studies in the patients that were on Isatuximab. Thank you so much to Sanofi and the Saudi Arabia organization for inviting me today. And I'm not sure if you all have any questions or if there's a little bit of discussion now.